Hey, everybody. Welcome back to Autism Confidential, the podcast from the National Council on Severe Autism. I am your host, Jill Escher. And you notice that we missed an episode last week, and there's no excuse for that apart from life. Things were just really crazy. I think everybody can appreciate how things crazy can get with our families. And I am not immune to that. So I apologize. But the good news is that we're back with an incredibly great episode this week with a great speaker. I also want to thank the people who sent in donations. Thank you. Woo, 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 woo. So if you're interested in supporting the podcast, you can do that through National Council on Severe Autism, ncsautism.org. Just go to the donate button and you'll find ways to donate. So thank you so much for supporting us here on Autism Confidential. You can earmark it or not earmark it. It's up to you. But we really, really appreciate the support. Okay, housekeeping done. I'm so pleased to introduce our guest today. And again, this was by special request because we've been getting so many requests for episodes. We've had more than one person write in and say they want an episode about dental care. So this is that episode, and probably not the last on this topic. I'm extremely pleased to introduce you to Dr. Alan Wong. He is Director of Advanced Education in General Dentistry in the Residency Program at the University of Pacific. And University of Pacific, which is here in California where I am, is known nationally as a leader in dental education. And he has he teaches in the special healthcare needs dentistry and hospital dentistry, which is focused on treating patients with intellectual and developmental disabilities and also patients with special medical needs. So he's a really special person who really understands our population. Welcome, Dr. Wong. We're so happy to have you.
Thank you, Jill, and please call me Alan. And I'm happy to be on your show.
Thanks, Alan. Yeah, this is great. Listen, I'm the mom of two kids with nonverbal forms of autism, and dental care has been an immense challenge for them. I think I can speak on behalf of our entire audience saying that dental care is a hard thing, and it's hard for many reasons. And I'm sure you already know this, but I'll just kind of put it out there as framing. Sometimes it's just hard even to brush their teeth, right? It's hard to floss their teeth. Sometimes they have terrible diets, and they eat things that might make them more prone to getting tooth decay. And then on top of all that, sometimes getting them into a dental office is hard. And then once you're in the office, getting them to open their mouth is hard. And if you open their mouth, keeping their mouth open is hard. Getting x-rays is hard. And then, if you have to do dental care, God forbid, that requires almost always, some form of sedation. So in my experience, every step along the way is really, really, really hard. And then, sorry to belabor the point, when they have tooth pain, you don't even know, because the kids can't say, "Oh, Mom, by the way, my tooth right here in the back is hurting." They'll just act out, and you don't know why, right? And so diagnosing the problem can be very, very hard. So I don't know if that resonates with you. But I wanted to put it out there before we even started talking.
Right. No, you've hit all the buttons and all the check marks, and you're absolutely right. And I think I stumbled into this field really more than anything. I've been in dentistry for over 35, almost 40 years now. And in my first part of my career, I did a lot of dentistry. And in the second half of dentistry, I'm sort of a recovering restorative dentist, meaning that you have to stop and say, why am I doing what I'm doing? And I realized that we don't emphasize the prevention part enough. We can take care of the after effects, which is holes in the teeth and broken teeth and whatnot. But the question is there anything we could have done to mitigate that in early parts? So from the beginning to the end, the lifespan of a person is very important to keep. And I understand that a lot of times patients with developmental disabilities of any type, or even aging populations, they lose benefits. I mean, as a child, most children, it can be seen by any dentist or any person, and then after a certain age, they lose some certain benefits, the adult benefits, if you will, right?
Mm-hmm.
So, and the problem with that is when they lose the benefits, they lose the prevention aspect of things. And that's the really key. If I were to drive anything home, I would say prevention is everything. Now, dentistry has changed a long way also in the certain time that there's new medicines that are tremendous, that are, and I'm going to talk about those briefly, but I think we have to change the mindset. And part of it is we need to be able to have government fund insurance that sort of focuses on prevention. And so the part you're saying about a person, if they don't get care, things get worse, they can't communicate very well, and usually it's a behavioral problem. So what do? They give medications, and two things happen. The problem gets worse, and the medications often cause a dryness of the mouth, which increases the chance of more dental problems. So we call it diagnostic overshadowing when we treat one thing when it's something else. We're treating a behavior when it's actually a different pathology. It might be a toothache, might be they got something in between their teeth or something of that nature. So learning to communicate with each person, because you know, you already know when you see one person with autism, you've seen only one person with autism has a different aspect, and that's not something they teach in dental school. You know, we're taught to drill and fill and, you know, take care of problems, but we really need to take care of the person more. So learning more about sensory modifications in an office, perhaps, learning utilizing behavioral support, training someone to have a successful appointment may look different than your traditional, you're going to go in there and get your teeth cleaned a certain way and x-rayed a certain way. We may need to think things differently as we move forward. So recently, there's been some great changes actually in the dental community, although it's not going to happen overnight. The American Dental Association changed in the right direction in terms of focusing on treating all patients with disabilities of all sorts. And that trickled down to a Commission on Dental Accreditation change that requires all dental schools, you know, throughout the country who are accredited to have education in both didactic and clinical experiences in treating patients with developmental disabilities and disabilities. So what we haven't been doing consistently throughout the colleges or the dental schools throughout the country now is mandated that they must do it. So that's a good thing coming down the pike.
That's
So,
great. Very good to know.
right. So knowing not only about the diagnosis and about the teeth, but the social aspects of it as well. So the problem is we don't have a lot of faculty that are aware of how to teach, and we don't have a lot of faculty that have great clinical experiences. So we're trying to grow that, if you will. We're trying to find the leaders in those areas to be able to teach things. So we do have a lot of people throughout the country that are very specialized, including your sister, in certain areas. So we want to incorporate the greatness of everyone and compile it into a uniform national oral health curriculum. And that's what we're doing. So
Wow,
we have a
that's
grant.
great news. Yeah.
We have a grant. There's 3 dental schools: University of Pacific, University of Texas, and Penn Dental have collaborated, and we're right in the midst of this national oral health curriculum that we're going to create. That's going to be fun. It's going to bring. We're going to share the beauty of humanity of people, first of all, and we're going to utilize this person by the name of Rick Guidotti. He's a terrific photographer, videographer that brings the beauty of people, and we're going to teach disability in a different way. It's going to be multimedia, so it's going to be downloadable for the dental students and the medical students. It's going to be interactive in a sense, in the fact that there's going to be PowerPoints for facilitators in the dental school, so there's no reason why they couldn't be able to present certain aspects of whether it's autism or cerebral palsy. But more importantly, we're going to talk about, you know, the social determinants of health, where we are in this situation, and we're going to focus on prevention.
Yeah.
So I'm very, very hopeful.
Well, let's talk about that, because I think our audience, you know, is very interested in absolutely minimizing to the greatest extent possible, right? Dental problems with their children, right?
Right.
I mean, certainly my dream would be never to have to take my kids to the dentist again for any procedure if I had a choice. But that would, of course, require exquisite hygiene. So I want to talk to you about that. I mean, you know, I'll give you an example. So my daughter, at first, like I couldn't even get a toothbrush in her mouth. Now we're using one of those, it's like a Braun electric toothbrush with a, I don't even call it, it has a twirling head,
Their head, yeah, rotating head.
rotating head. It's sort of like, kind of like how they clean your teeth in the office, but a junior version of that. And now she can take that for almost a full minute in her mouth, which to me, that to me was the biggest change, right, for her hygiene, that I was able to use this very powerful toothbrush. In addition, I have a high fluoride toothpaste that I get at the doctor's office, at the dentist's office. She has had like those fluoride treatments on her mouth, like when she goes in, that, you know, where they put some paste on. So I'm wondering if you could maybe give us like your top 2, 3, 4, 5 kind of hygiene ideas for prevention for our kids.
Okay, very good. All IDD, and I'm with Special Olympics and do this worldwide. So #1 unmet need is dental. So yeah, so that's pretty common. So the key thing now is fluoride varnish is very important. One application of fluoride varnish may last up to 3 to 4 months in efficacy. It doesn't stay on there for that long, but it can be very helpful depending on the age of the child. Or the adult even. So it's not even child, adult as well. As you know, medications, it's all about acid and base. So depending on the patient's natural saliva, whether it's acidic or basic, or where the medication sometimes change the quality and the quantity of saliva, the key is neutralizing acids. If you can neutralize acids, you can help lower cavity risks. So I would say the #1 thing is being aware when someone's mouth is kind of dry, it's more apt to be acidic. And if the saliva is thick and ropey, it's most likely not working very well. So if you can get someone to rinse their mouth frequently, like after they eat and whatnot, that is immense. That's really important. I have this cup of coffee in front of me right here. Not selling the coffee, but I'm saying when I drink something that's acidic, it stays in my mouth for a while. And it takes a while for your saliva to neutralize it. For patients that have impaired saliva, it may be acidic for a very long time throughout the day. So, acids like orange juice or apple juice or anything like that have a lot of sugars, unless they're washed out, then they're going to stay there slowly eating away at the teeth. Now, if you neutralize it, then it stops. So if you're going to have something acidic or something that's like that, encourage your child to rinse, or you don't have to drink a lot of water, you have to just rinse. That would be really good. Making sure the person's hydrated is very important too, because that helps for saliva as well.
Okay.
My goal, you were saying your goal is never to bring someone to the dentist. My goal is for you to bring the dentist and then have a great experience. And if it's just meaning painting on varnish that protects the teeth, that would be the best. Because I think that there's a time in our place in our world that fillings and extractions have to be at a minimum, because I see them in the hospital and it's because of all the neglect, because they can't get in, like you were saying. It's painful and whatnot. So the other part is the caring for the teeth, to be able to retract before you brush, meaning like just don't jab a toothbrush in there. Sort of take something, whether it be a plastic spoon or something, to pull the cheek away. So when you're brushing, you're not brushing into their gums, because when you hit the gums of someone, it hurts. And then you develop this aversion that I don't want someone to brush my teeth. And that makes sense too. If you had someone brush your teeth, and even when you went to the dentist, when a dentist accidentally hits your gum, it's not fun. So you learn to not want to do it. But if you do it gingerly, and I'm not selling this, but I designed a retractor that's nice and soft that helps to pull the cheek away or the tongue away, so that I can see what I want to do. Then I could do it carefully. And actually, when the person is self-determined and they can do it themselves, where they're retracting and they're brushing themselves and seeing what they're doing, it's a lot easier than it's arbitrarily brushing, right? So we need to think about sensitivity and about what goes in the mouth, what type of flavor, texture, whatever the patient likes. And then
would it be advisable, you mentioned the fluoride varnish is providing protection for a couple months. Would it be advisable for our families to take their kids in just to get the varnish? Is it medically ill-advised to use varnish, more than twice a year? I mean, what's your sense on that?
I think that just like medication, you use it the way it's appropriate. That's appropriate. So if there were high cavity risk patients and extreme cavity risk patients,
Mhm.
absolutely. If they're low cavity risk and their saliva is fine and not apt to get cavities, I wouldn't do it just to do it. So
Mhm.
how do you know that? Well, you don't know unless you measure it. So at the dental school, we teach this caries risk management technique where we're checking for saliva, how much is coming out, uh, whether it's acidic or whether it's basic. And we have even checked the plaque to see if it's acidic or non-acidic.
I've never seen that done in a dental office.
Oh, okay. Well, it's kind of a newer science kind of thing, but
Mhm.
most patients on the ordinary that aren't taking medications that dry their mouth, like all
Mhm.
the medications that take care of mood, dry mouths, that they do. And so
Interesting. And where our kids are on a lot of those medications, you know.
I know. And so when they have bubbly and thick saliva, that's a problem. So those type individuals, those would be ones that we teach in the dental school every 3 or every 4 months is necessary.
Mhm.
Because what's happening is teeth are softening, and all of a sudden you have a cavity.
Mm.
But so we need to protect it. It's not like waxing the floor, if you will. So sealants help because they release fluoride, but varnish helps because it adds a thicker layer.
Right. And
Uh,
the sealant is, maybe explain what a sealant is and when it's indicated.
okay. Sealants are it's like when you have cracks and grooves and on the floor. If you had tile floor, you have these little seams and cracks, right?
Mhm.
And stuff gets trapped in there. Well, the same thing. If you have deep grooves in your teeth, no matter how well you brush, the deep grooves harbor the bacteria and the sugars in there. So no matter how you
Mhm.
brush, you can't get to the deep grooves. A sealant covers that deep groove so that bacteria and food cannot develop a cavity in there.
Oh, okay.
And
Okay.
yeah, so the nice thing is if you do it when you're younger, there's no local anesthetic. It's just very easy to do. And they have some sealants that are very, very effective that release fluoride, glass ionomer sealants that I really.
Wow. I don't think my kids have those. Um, how much compliance does it require on part of the patient to get that procedure done, to apply the sealant?
The ones that take light curing take very high level of compliance. There's some that don't need what's called a light cure, that blue light.
Mhm.
Those
Mhm.
are what's called glass ionomer sealants, and they work very, very well. They're the only regenerative kind of material that releases fluoride and protects the tooth. It's anti-cariogenic, so it fights cavities actually. So it's a really
Mm.
brilliant thing. So
Huh.
in my world, if I could put sealants on all the grooves of the teeth, because that's where most cavities are, that and in between teeth. If I can put sealants on there and get them in on regimen of fluoride, I feel as though that we have a good chance of decreasing cavities in
Mm.
this population.
Wow. Yeah, I'd never heard of those sealants. I wonder, are those common in dental offices now? Like if you went in and asked for it, your dentist would.
Sealants are common. Glass
Oh,
ionomer sealants, probably
yeah.
not so much, but
Okay.
you can say, I hear about this glass ionomer because the sealants work, but in the wrong condition, it doesn't. So, in someone who's compliant, the resin sealants, which are what you normally hear, those work very, very well and very effective. But if they leak, you get a cavity. The other one,
Mm.
the other one, if you put it on, it actually, if it fell out, actually the protective properties still are there. It's very, very good.
Hmm. Wow.
Yeah, it's the same cost.
Okay.
Yeah.
All right. So
And
we've talked about a little bit about brushing. We've talked about fluoride varnish. We've talked about sealants. Let's talk more about toothbrushes. So, as I said, I with my daughter at least I was able to change from, your standard issue, Colgate toothbrush to this, spinning head toothbrush. And I noticed an improvement in her, at least the look, right, of her
right.
teeth. I noticed what seemed to be less plaque, less buildup. What do you recommend to people in terms of just toothbrushes? There's so much technology out there. There's a lot to choose from.
Okay. The answer is whatever ones they like, really. I would let them pick their own, but there are some very neat things coming out in the market. There is one that has AI technology, artificial intelligence technology.
An AI toothbrush.
Yeah, yeah. So
Okay.
what happened? I don't have one right in front of me, but it's a toothbrush that works with its iPhone. And as you're brushing, it tells you where you are on the process and gives you sort of a timer, and it gives you certain rewards. But the key thing is because the artificial intelligence tells the toothbrush where it is in your mouth, whether it's upper jaw or lower jaw, it helps to focus the patient into what area to concentrate on their brushing. And Colgate, I think, puts it out. I forgot the key name on it, but it's inexpensive. It's it's not much. It's less than the other one, but it's something that's out in the market. Might be good for some people that are into kind of that kind of reward system, to see that, but encourage them to do that. I would use softer brushes if possible. And this retracting the cheek and brushing the front teeth first until they get experience, and then move towards the back and the roof, the tops of their teeth. I think everything is just like desensitization, getting them used to something, not forcing it on them. Do it where they want to do it. You don't have to do it all toothbrushing in the bathroom all the time. If they want to do it watching TV, maybe that's something you can get them to do, and have a little bowl in front of you just to wipe out or spit out. But I think a lot of it's sensory, a lot of sensory as well as taste and flavor and everything like that. So start brushing without any toothbrush, and when they're young and they get used to doing something, put a little piece size on there of whatever toothpaste they want, and not a lot of it.
Does it matter? Like, is there a certain kind of toothpaste you would recommend more than others? I mean, I imagine you would recommend fluoride toothpaste, but
I would, but if you're doing fluoride therapy, varnish and that stuff, I'm more interested in them physically removing the debris, and then doing the fluoride later. But if given a choice between you want to use fluoride toothpaste or non-fluoride toothpaste, and obviously depending on age, what you want, because you don't want to swallowing a lot of fluoride. But you get that in the natural water sometimes too as well, but within reason. So don't overdo it. But I think the actual mechanically removal of the plaque and food particles is really important,
And what about that? Of course, leads me to flossing.
Yeah.
I finally, I just started using those. I never wanted to use them because they seem so environmentally offensive, but those plastic single use
Yeah.
pick, the floss picks. I finally
Those are
started.
good.
Yeah, it worked better for my daughter, I have to admit. What advice do you have about flossing generally?
Right. Well, self-determination wise, floss picks, if they like it, that's great. There's another thing that looks like a fork that it's a floss holder. And
Yeah.
you can take that's a little bit more environmentally friendly because you just add that and then able to do that with a handle. But whatever you do, just do it gently, do the front teeth, get used to the feeling of it, and then move to the back. And very important as well. But if you can get in the brush really well and do the fluoride varnish, I think those are two key things.
Yeah.
Flossing obviously is very important, but that's a challenge for even neurotypical patients,
So do you have any other kind of basic hygiene tips before we move on to the question of clinical care? Like what happens in treatment?
Okay. Before we go on that's in between that,
Mhm.
there's a new thing that's come out in the market. Not new, not super new, but it's kind of a new option. It's called silver diamine fluoride, SDF. It is what we call the magic bullet. So for pre-cooperative patients, you see a cavity and the patient doesn't want to sit down and have the work done, let's say.
Mhm.
You have two choices. One is you're gonna hold them down, give general anesthesia or whatever, and it's just not a thing that you want to encourage at the right time. It may be just that the patient's scared right now, right? There's this stuff that you just paint on and it stops the cavity from growing and
Oh,
hardens
wow.
the tooth.
Oh, wow.
It hardens the tooth. The side effect is whatever is a cavity, it kills it and turns it kind of dark, kind of gray black. Now, that's not forever, but it's like putting out a fire and then later on going back and cleaning things up.
Yeah.
So,
Okay.
so for patients that have small cavities are growing that they're not very cooperative with,
Mhm.
we can actually stop it with this, harden the tooth so that when you go back, you don't have to take away as much tooth structure. And it
Wow.
doesn't require being numbed up at all. So silver diamine fluoride is something that I see in our population that are difficult to get into dentistry to get the work done. Can we do this to stop certain things from growing and getting bigger until
And
they
how
are.
long would that last? Let's say you did that treatment in the office,
Huh.
right? Do you need to then maybe get the, cavity filled in a year? Like, how long do you postpone the inevitable?
Well, the answer is as soon as possible, but it does work right away. It works somewhere between 60 to 80% of efficacy on the first application. And then if there's a second application, it works more. But many of my patients have very much not enjoyed, but it does two things. One, it stops the cavity, and it stops sensitivity too.
That's
So
important.
that's kind of nice thing. So when surveyed, parents are asked, if we're to do this, are you offended by the dark spot until it's gotten fixed? They said absolutely not, because
Yeah, the least of our worries. Yeah,
not the least you worry. You just don't want your child to suffer in pain. You don't,
yeah, right.
a dark spot's better than no tooth, right?
Yeah,
Right.
for sure, for sure. Interesting. Okay, well, let's move on then to talk about clinical care, because of course that's a huge challenge for our families. As I said, sometimes just getting them physically into the office, getting them into the chair, getting them to open their mouth, just getting an exam. I don't think my daughter has ever had dental x-rays. Oh, no, she did, because she had to have she had to have a tooth extracted. I forgot she did have them once. Um, but what do you teach in terms of just clinical management for your, and I'm talking about here this time, a routine office visit. I think, and then I also want to talk about, the actual, treatments when there is, for example, a cavity or a need for other intervention.
Okay. Well, let me start it off, but it might be another podcast because
Yeah, really, this could go on a long time.
yeah, you have all day, right?
Yeah.
So I think developing relationships are very important. When an office is available for a teleconference or video conference, I think it's not a bad a thing, because here at our residency program, we talk to the patient ahead of time and find out what certain things about the patient first. And I think that's kind of keen, because if I know certain things like negative dental experiences in advance, I want to know what they are so that I don't repeat it,
Mhm.
first of all. So I think if an office is able to do telehealth, televideo to familiarize each other, and would be brilliant if you could
Can
do.
you like look at their teeth? Like,
You can look at their teeth, but I think more importantly for the patient knows a voice and a person that they may
mhm.
see, answer some questions, and sort of given the imagery of what you're going to expect when you come in. So that'd be nice if they can do it. And this is not always ideal. The other ideal thing is to get a dental visit tour. So we'll do those usually in the morning when there's not a lot of people around. Just come in, check out the dental chair, check out the environment, and see what they're going to have done. It's like a tour, just like any other huge procedure, because this is kind of scary stuff for a lot of people,
Mhm.
neurotypical as well. So all these extra noises. So we'll run the
Oh,
handpiece.
the noises.
So we'll introduce them to certain. Here's the noises and sort of smells and certain feels, and this is what this is. Do you have any questions? And it might be like a 10 or 15-minute like mini tour. I think that incremented successful visits
Hmm.
develop trust and rapport, right? And then here's the x-ray machine. We're going to put this lead shield on you, and it feels like
Mhm.
a weighted blanket, so they can see everything ahead of time. Then schedule. If they're wanting to do it that day, great. If they're not, I wouldn't worry too much. In my
Yeah.
private office, I'm not going to schedule an hour and a half for someone that I have not met and has some sensory issues. I'm going to let them lead how things are done. Now that is atypical, mind you. So you have to find offices that are willing to do that.
In my experience, it has been, I have two kids with pretty severe autism. Um, that I'm going to just be honest, all of that introduction, all of that sort of familiarization would not make that big of a difference. They're still going to be very difficult patients. It might help a little bit. I think it'll help more for certain patients than for others, right?
And that's where the televisit would help,
Hmm.
because you know the patient and the patient knows
Yeah.
the patient better than anything else.
But
Right.
like, okay, let's say we just want to get x-rays of my daughter, right?
Okay.
She's not going to let you put in that film thing in the side of her mouth. She's not going to chomp down, and she's not going to sit quietly, right, while you take the image. Um, do you recommend sometimes that these children do have some sedation or something before a routine visit? Or what do you do when they just will not cooperate, even after you've done all of the kind of acclimatization?
Okay. In the state of California, you have to take a look at the mouth before you order the x-ray. And so if we think that an x-ray is necessary, essential, then that would sort of dictate whether you need pre-medication or not pre-medication for certain procedures. There's also an extraoral x-ray which goes around the head, which is sort of nice. So nothing really goes inside the mouth except they bite on this little stick in the front. And if they were shown what that machine looked like and say, hey, can you stand for, 20 seconds on the clock or whatever it takes to pass your head externally, then you've achieved the thing that you need, which is the x-ray, and you not stuck something in someone's mouth.
And that x-ray machine is in a standard dentist's office, or do you have to go to a
Mm,
specialist?
When you call in, just say, do you have a Panorex?
Anorex.
Yeah, Panorex is a machine.
Okay.
And depending on the age of the child, or depending on whether if they're in a wheelchair or whatnot, there's certain limitations. So that's where the office visit is very important, because they
Mhm,
get to see the machinery, they can see how the machine turns, and in
mhm.
their head get an idea of, okay, I'm going to stand here, and either they can close their eyes or they can do something, or they can hum, whatever, and for that period of time. So that's walking them through that process. But we have to take a look at the mouth before we order the x-ray. But if you're
Okay, now, but you said that you could order pre-medication if necessary,
right,
right? So dentists have the authority to do some prescribing. So what do you tend to order when there is a case that needs that?
there's can and then there's will. So we
Right.
can't do it. Even though we can do it, a lot of times you'll find dentists a little reluctant because if a patient is on other cocktails, if you will, other
Yeah.
medications, they
Mhm,
can greatly affect it. And honestly, we would probably confer with the pediatrician or pediatric or the physician, whoever, whatever age group it may be, in terms of medication, because sometimes it's just a simple bump up of what they already have,
mhm.
right?
Right.
And instead of adding something to. So this is where the collaborative care comes in. We have to really talk about what's the best strategy. To that end, I would say, if possible, get early morning appointments, because you don't want them in the afternoon when the medication is kind of at its worst, or if they've had a
When
lot
it's
of
when.
activity, a lot of activity at the day. So I would say for new appointments and whatnot, try to schedule an early morning appointment when they're at their very best to
Mhm,
tolerate. Or
mhm,
if you think they're best to tolerate in the early afternoon, choose the time where they're the best able to handle new
mhm.
things and stress.
Um, yeah, we've had to do that too. I think I wanted, gosh, we're running short on time, and you're right. Like, we should probably have another episode because
Mm.
there are so many issues about access to care. And that includes, I think, two things. First of all, sometimes finding a practitioner who, will take a child, or more typically an adult, right, that has a lot of complex behaviors. And then, of course, there's the double insurance issue. There's the insurance issue around just the clinical care, whatever has to be done by the dental team. But then there's the anesthesia issue, which is almost never covered by insurance, at least in my experience. And these things are really big for families. These are real hardships. And I'm kind of thinking that as much as I want to talk about these, that this should wait for another episode because we're at the end of our time, and I think this is going to take us a long time to work through some of these topics. Is that okay? Would you come
I
back? Maybe we
totally,
can talk next week, and then we can post that the following week.
I totally agree, and
Okay.
we'll find some time to do so.
Yeah. Okay. No problem. I'll be around. Alan, thank you so much. As we know, we're going to have you back for
Okay,
part two
looking forward
on
to it.
dental care with autism. So thank you so much, and I will talk to you soon. Thanks for tuning in to Autism Confidential. If you'd like to learn more, share an idea for an episode, or become a sponsor, please visit us at autismconfidential.org. The views expressed in this podcast are solely those of the individual speakers. Content presented is for informational purposes only, and we do not provide any medical or legal advice.